Hi guys, welcome back. We shall now be talking about aspects related to hepatitis B. I would like to first address a question which is usually a problematic issue for most students because of varying answers. But this is what Harrison says, that the leading cause of transfusion, blood transfusion associated hepatitis is hepatitis B, and it is not hepatitis C. So I have addressed this question right away. The second thing that I would like to highlight is that they can give you a clinical based question with this electron microscopy image, where he will first describe prodromal symptoms like nausea, vomiting, aversion to smoking initially, and then person is having development of right upper quadrant tenderness, tender hepatomegaly, increased liver span, and the doctor sent the sample for viral markers as you would do routinely, because at the moment you don't know which virus is contributing this viral hepatitis. But then the blood sample of this patient was subjected to electron microscopy, and at 1 lakh times the magnification, you can see the virus which is present here in both spherical format as well as, I would say, rather tubular or filamentous format. So if you are going to get a virus like hepatitis A or C, it will always be in spherical format. But here you can see two forms. One is the spherical and second is the tubular form. And therefore, this electron microscopy will help in confirmation or diagnosis that this is hepatitis B that is being visualized. Second, along with the clinical history, they can ask you to point out the antigens which are seen with respect to the virus. So the one that is on the outside is obviously the surface antigen, that is HPSAG. There is the nucleocapsid core. This will never come in the bloodstream. It is found in the nucleus of the hepatocytes that it will infect, but it never comes in the bloodstream. The antibody to it will obviously come, but then the core antigen is never found in the blood. The yellow marking here is symbolic for hepatitis B DNA, and then you can see this star. I'll just zoom it in so that you can appreciate better. You can see the star representation which has been shown in this diagrammatic representation. This is hepatitis B E antigen which is secreted into the bloodstream because this is related to the endoplasmic reticulum, and this E antigen is a marker for replication. It also indicates the infectivity of the virus. At the outset, I would also like to mention that in mainly Mediterranean countries, Ukraine, Russia, central part of Europe, there is a form of hepatitis B virus that is not able to express the E antigen. The clinical features are even more severe than the Asian virus, and this, I would say, the Russian virus, which is more dangerous than the Asian virus, is called as precore mutant, and it lacks the E antigen, and therefore the replication of this would not be detected routinely. So for detecting the replication of the precore mutant, you obviously have the backup of using hepatitis B DNA, but I just wanted you to be aware of that. What do you mean by precore mutant? It means that E antigen is not expressed, so you are not able to identify the replication of the virus in the bloodstream, and the course of this precore virus, which is common in Mediterranean countries, Russia, Ukraine, etc., is relatively more severe as compared to the Asian virus. Then is it a single stranded virus, double stranded virus, as they ask routinely? So do remember, it is not a double stranded virus, it is a partially single stranded, partially double stranded. You see, the questions will always be on the genome of a virus, and this has a circular DNA. Most of the chaps very casually mention it is a double stranded virus, whereas if you read the data, it will say that this particular virus has a 3.2 kilobits kb, the small b, not bytes, bits, 3.2 kb circular DNA, which is partially single stranded, partially double stranded. I repeat my statement: the DNA of this virus is partially single stranded and partially double stranded. Please do not mix it with the second statement that I'm saying here, that this virus has double shell. It has a double shelled virion. The usual size is mentioned to be 42 nanometer, and then you can see that the E antigen is the one which is related to replication of the virus. So we will next study that how is this virus transmitted, the routes of transmission to be remembered, and the most common route of transmission in young people is mainly sexual contact, or it is percutaneous route of transmission, which would be responsible for spread from one person to another. Hepatitis B is actually not so dangerous as it is made out to be. You see, it is hepatitis C which is more dangerous, because C, majority of cases, you will find person getting converted into chronic hepatitis. In hepatitis B, recovery is usually the rule. I mean, 90% of cases, the patient will recover even without any medication. You don't need to give any tenofovir, entecavir, lamivudine, pegylated interferon, all those fancy stuff that you study, nothing needs to be given. Our human body is so strong that it can produce antibodies against the surface antigen, and 90% cases never come for a second consultation altogether, because the jaundice starts resolving, the right upper quadrant discomfort starts disappearing. So 90% cases, because there is a seroconversion with respect to the protection antibody, that is the antibody against the surface antigen, most patients do not come for second or third consultation at all before you, and there is no need to give antiviral treatment to the patient. Whenever you give treatment, it is only for patients of chronic hepatitis B. We never give treatment for acute hepatitis B. Obviously, conservative management for nausea, vomiting, etc. would be done. Dehydration component would be handled. So the leading cause of transmission of this is sexual contact, heterosexual contact. Mostly in Asia, it is sexual contact only. And then apart from this, obviously, it can be blood transfusion. Now, when it comes to blood transfusion, I have highlighted right away that of all the viruses, the one that has the highest predisposition to be transmitted is hepatitis B. But because blood transfusion has capacity to transmit other infections also, so government of India has made it mandatory that blood is tested for the following antigens before it is transfused into anybody else, and that would be hepatitis B, C, HIV, syphilis, and malaria. For hepatitis B, you will have to test for the surface antigen, the Australia antigen, because called it Australia antigen because it was initially detected in the original inhabitants of Australia, that is aboriginals. Then for hepatitis C, you will be doing a EIA enzyme immunoassay anti-HCV antibody. But the problem is that this antibody will take some time to appear. So if a person had a sexual contact or did needle sharing via IV drug use, for early identification, the test you can use is PCR HCV RNA. So you would expect your blood bank officer to be using both the tests, that is EIA and PCR, to identify hepatitis C. For HIV, we are now having a fourth generation ELISA test which can become positive fairly early. But still the problem is that if a person had sexual contact, let me say 2 days ago, 3 days ago, and then he donated blood in a blood camp, like this is what happened in Tamil Nadu, no, last year in 2018-19, what basically happened was this young chap in Tamil Nadu, he was a college student, he went to a red light area, then he had sexual contact unprotected, and then in his college there was a health camp that was organized. So he donated blood in the health camp, and because he was in the early part of the disease of HIV infection, the tests of ELISA turned out to be negative. Though the sensitivity of serum ELISA fourth generation is 99.5%. I have discussed HIV separately, you can go through that section. But because the sensitivity is 99.5%, I mean, initially we'll get an impression, okay, fine, the guy does not have a disease if ELISA is negative. But this chap was having the virus in his blood because it was early part of the infection, and the blood bank officer did not run a PCR. Now, had the PCR been run in this guy, then we would definitely be able to identify the disease in the window period, in a sense that window period here applies the fact that, the antibodies ELISA will take some time to turn positive. So before the detectable antibodies will appear, you can use PCR to identify the disease early. So PCR HIV would be done in the patient for early identification. So blood bank will be expected to do proper testing, because I'll put it like this: if there is a person getting transfusion associated infection, the responsibility is always yours. They will put the blame on the prescribing physician. They might penalize the blood bank also a little bit, but they cancel the license of the doctor. So every time you're associated with any private blood bank, you always have to ensure that proper testing is done. For syphilis, it is FTABS. You're aware of the fact that in syphilis, VDRL is to be answered for two scenarios. One, if he says what test is to be done to diagnose neurosyphilis, you will go for CSF VDRL. And the second test that or the second scenario where you will answer will be vertical transmission, where like if the mother, she's having syphilis and the baby also ends up with syphilis, then the antibody titer will rise. So four-fold antibody titer or dilution factor for VDRL will help you identify that the baby has also got the infection from the mother. The commonest type of malaria in India is falciparum malaria. For this, we have a dipstick available. that is HRP2, that is histidine rich protein 2 dipstick available apart from peripheral smear, which can help you in early identification of falciparum malaria. So these are some common infections, can be much more than these. No, it could be West Nile virus, parvovirus that can be transmitted, but then these are common infections for which blood should always be tested before it is transfused into anybody else. And out of all the viruses, hepatotrophic viruses, hepatitis B has the highest chances of being transmitted. That's why I said transfusion associated hepatitis. Now, the third route of transmission that you have to remember after this would be vertical transmission, mother to baby. For this, he can give you a case-based scenario like this is a commercial sex worker, CSW. She's in the third trimester of pregnancy. She came to a government hospital today. She is registered with the STD clinic of your hospital and you are the intern posted there. So you saw that she was carrying a printout of reports that were mentioning that she's surface antigen positive as well as E antigen positive. And this lady, she saw that she's uneducated. She doesn't understand what these reports basically mean, but she saw you seeing the reports with a lot of care. So she asked you, doctor, is there something wrong? So you told her, yeah, you are having a disease and your baby can get infected. So after all, she's going to be a mother very soon. So she asked you, okay, doctor, what are the chances that my child or the baby who's going to be born will get the disease? So you told her a figure of 90%. And she was like, looking at you and saying, doctor, are you serious? 90% chances that my baby will get a disease of mine that I'm carrying. And she says, doctor, can't you reduce it to 0%? She, after all, is asking you to downgrade the vertical transmission which can occur. And most of the time, the transmission occurs at the time of the delivery. You see, when the baby is born by the birth canal, he will be exposed to body fluids. So eyes of the baby will be exposed to maternal secretions. They would be swallowing of maternal blood by the baby. So various routes of transmission. Majority transmission occurs at the time of delivery, apart from transplacental one that may have occurred already. So in this case, what will you do? You will tell her that we will give your child hepatitis B immunoglobulin, and this immunoglobulin should be given parenterally, ideally parenterally, and should be given as early as possible, preferably within 12 to 24 hours. In fact, the current edition of Harrison has mentioned it to be 12 hours or as early as possible. Ideally, I would say get the procurement of this in advance, because she came to you for antenatal checkup, so procurement is already there. So after the baby is born, after 1-2 hours, when the baby is stable and the mother has started feeding the child, you can give hepatitis B immunoglobulin to the child. This is a standard SOP, standard operating protocol, that the vaccination has to be given. And along with this, the hepatitis B vaccination is also to be done. So if in the question he mentions immunoglobulin, vaccine and a combination of the two, you will have to answer a combination of the two. Why? Because the passive immunity will last for only a short duration. After all, the active immunity has to take over. And the Government of India protocol is anyway to give this vaccination on day 0 of life, then on 6 weeks, and then at 10 weeks. Or if they're busy and they can't come at 10 weeks, then they can give the shot at 14 weeks. So initially 3 dosages are recommended of the hepatitis B vaccine to build up the active immunity in the patient and prevent the child from getting the disease. Usually we have seen that if the vertical transmission is there, the disease in children is very, very severe, as compared to when I was saying, no, adult will have a disease, he might not come back for second consultation. Why? Because adults, the immune system is well developed, so usually recovery will occur. So the severity of the disease is more severe in infants, and the conversion of these patients into cirrhosis or end-stage liver disease or chronic liver disease will be higher as compared to that in cases of adults. The vertical transmission is to the tune of 90%. Then is accidental needle stick injury. You see, the doctor knows that this person is surface antigen positive. Let me say this guy has decompensated. He has developed ascites. He is also having esophageal varices. And today he came to you because he required a ascitic tap. So before ascitic tap, you were doing baseline investigations for the patient, like electrolytes have to be checked before doing ascitic tap in a patient. And you took a sample of this guy. You used double gloves. So the doctor on duty used double gloves because he knows that this is surface antigen positive patient. But unfortunately, the doctor was putting cap back on the needle, and the needle stick injuries always occur when the recapping is done. You all know from your training sessions that you are never ever supposed to put cap back on the needle. Always carry a portable needle cutter. When you draw a sample from the body of the patient, put the needle in the needle cutter, cut the needle, then handle the remaining hub of the syringe which is carrying the blood sample of the patient. But this doctor on duty did recapping and he got a prick. The moment he felt the prick, obviously it was painful. He took off the gloves, double gloves, and still there was pain because the cutting is a needle. can be needle, can be sharp enough to go via the double gloves and cause blood. So this guy, he's literally freaking out. He's asking you, he is a junior of yours, he's calling you up, he says, Doc, what is the chances that I will get hepatitis B? And let me say, this doctor in turn had not even taken vaccination. And very frankly speaking, I'm speaking this from personal experience. I've been teaching for so many years. I've had doctors who listen to this discussion and still don't bother to get hepatitis B vaccination done. And in their internship, in the first few days, they get a prick from maybe a patient whose status they don't even know. And in India, considering the wide expanse of the disease, you never know who's having hepatitis B or not. So definitely, I mean, you should get vaccination done. And I have had, I mean, brilliant chaps, freaking out because they never got vaccination done, or they had got vaccination done, only one shot of vaccination. Like right on the first day of internship, they went and got vaccination, and within first few days they got the prick. So now this guy is wondering because he has taken only one shot of the vaccine and he's got a prick. So before you start your internship, the primary course of vaccination should have been complete. 0, 1, 6 months, 3 shots to be taken. This in turn, this doctor had not taken this vaccination schedule, or maybe one shot of vaccination. So obviously the immunity will not be stepped up. The chances of transmission of hepatitis B is a huge 30%. Unlike HIV, where the chances of transmission are a mere 0.3%, here the chances of transmission are a huge 30%. So we need to be careful. Therefore, the guidelines are that the doctor should be given hepatitis B immunoglobulin immediately. Here, I would like to mention the fact that if there is conjunctival inoculation, like this doctor was taking blood sample of a patient and there was a spatter of blood on the face, there was splashing of blood on the face of the doctor, or he's handling trauma and there's splashing of blood on the face of the doctor and he's not using protective goggles, then the virus that is with the blood will land up in the conjunctival inoculation will occur, and this will also have a substantial risk of transmission of the disease. So whenever a doctor is exposed to infection, you should be giving hepatitis B immunoglobulin to the patient as ASAP, as early as possible. Ideally, preferably within 6 hours, but they say that you should identify a center in advance. And if a doctor's had a prick like this, then the administration should be done on a priority basis. This is for the doctor had not taken vaccination. If he's already taken a vaccination, then nothing is gonna happen because he's protected. But then lots of time doctors might take only one shot, two shot, forget about the third shot, or they have not taken it at proper spaced intervals. So ideally the course of vaccination should be, the primary course of vaccination for hepatitis B should be complete before you get into the hospital and you start doing samplings of your patients. And never put cap back on the needle, because there have been instances when doctors have unfortunately got this infection. Now once we know about the routes of transmission, we will now discuss regarding how the virus will manifest in the patient, what will be the antigens that will be appearing. So the first antigen to appear in the blood is surface antigen. The question will say earliest serological evidence of hepatitis B infection is, answer is hepatitis B surface antigen. It usually appears between 1 to 12 weeks of infection. Most of the, it's a long time, 1 to 12 weeks. Most of the time the positivity of surface antigen will begin about approximately 4 weeks after the onset of infection. Remember, first surface antigen will turn positive, then SGPT will begin to rise. So it precedes SGPT elevation in the patient by at least 2 to 6 weeks. This will be followed by development of jaundice in the patient. So do remember the fact that first you have surface antigen appearing, then you have SGPT starting to get elevated, and then jaundice will occur. And most of the time the jaundice will disappear, and then SGPT will come down, and then surface antigen will disappear. So surface antigen is the first one to appear out of the 3 and the last one to disappear out of the 3. Mark my words there. If you compare surface antigen, SGPT and jaundice, first is surface antigen, then is SGPT elevation, then is jaundice. Jaundice will disappear, then SGPT will come back, then surface antigen will disappear. Usually before 6 months you would be having, that is 24 weeks, the surface antigen will begin to disappear from the bloodstream of the patient. That's when the protection antibody will start taking its rise, or the surface antigen antibody against surface antigen will start rising. That is the time by which the antibody to the surface antigen will begin to rise in the patient. As I've emphasized, the nucleocapsid antigen or the core antigen, this will never appear in the blood. Antibodies can be formed against it, but it will never appear in the blood. It lives in the nucleus of the hepatocytes. Then is hepatitis B E antigen. This is indicative of viral replication. It is indicative of infectivity of the virus So if E antigen is positive in a sample, then the person will be highly infectious to his or her sexual partner and also to the doctor or nurse handling the sample, because if they get a prick, they can also get infected. Then is hepatitis B X antigen. The question that is asked on X antigen is that it predisposes to development of liver cancer by inhibiting apoptosis. It inhibits CD95, it inhibits apoptosis and can trigger development of hepatocellular carcinoma. Hepatocellular carcinoma in India is mainly seen with hepatitis B, though in Robbins it is given in Western population it is C virus, but in India it is hepatitis B virus. In fact, for liver cancer, I'll put it like this: that first answer as hepatitis B. I'm taking reference of Harrison here. Hepatitis B more common than hepatitis C. Why? Because in America C is more common, so their liver cancer is seen with C. But majority of cases of liver cancer are found in Southeast Asia and Asian country and some parts of Africa. In both Asia and Africa, it is hepatitis B that is the leading cause as compared to C. So repeat the data once again, not that only Harrison is saying it. The bottom line is that in which countries liver cancer is more commonly seen, it is mostly in Southeast Asia. So therefore the answer has to be given on basis of where maximum cases are seen. So I agree to the fact that in Robbins it is given C virus, that's for American population, but in India, Southeast Asia it is B, and you can check out hepatocellular carcinoma, first paragraph in Harrison, where is first mentioned about hepatitis B as the leading cause on the basis of the logic that I've said, that because maximum cases are found in Southeast Asia, the common etiology agent first should be answered as hepatitis B virus, B for Bombay. The next antigen to be remembered for this virus is hepatitis B DNA. We will be quantifying the viral load by doing a PCR hepatitis B DNA. Just to create a case-based questionnaire, he might tell you that this is a diagnosed case of chronic hepatitis B. He is hepatitis B E antigen positive / reactive. That means the virus is still actively multiplying in the blood of this patient, and the viral load of the patient is more than 2 into 10 raised to power 4 international units of DNA circulating per ml of blood with, mark my words there, with doubling of SGPT. So you can see here that one, I have demonstrated that person is E antigen reactive plus enzymes of the liver are rising, because the most specific liver function test is SGPT, that is ALT. So the virus is multiplying actively, the SGPT enzyme is elevated, so I need to put a check on this, because if I don't, then the liver will be damaged and there would be cirrhosis developing in the patient. So the drug that you will use for treatment of this patient in this particular case, and is the drug of choice for hepatitis B, is tenofovir. Alternatively, we can also use entecavir. In earlier time, we were using interferon for these patients, like alpha interferon or pegylated interferon. But with the turn of the time, we are finding that this virus is gradually or has become resistant to the conventional treatments that were being used earlier, like lamivudine, pegylated interferon. We still use lamivudine and pegylated interferon, but overall, if you ask me the drug of choice for this condition, considering the that we are using PCR to monitor the sustained virological response in this case, that the virus load in the person will progressively decrease, then if you compare the various drugs, then tenofovir and entecavir, first tenofovir then entecavir, are having an edge over the remaining viruses. So let's have a recap of the aspects that I've highlighted for this virus. One, it is surface antigen, that is the first one to appear. Core antigen would never appear. E antigen indicates replication, and X antigen is suggestive of cancer. Now, once we studied this, our objective would be to study aspects related to antibodies related to the virus. I'll just jot down the three names here: antibody against hepatitis B, surface antigen; antibody against the core antigen; and antibody against the E antigen. And sometimes this antigen word may not be written, because then it can cause confusion, but I wanted to first highlight that antibodies against these antigens are being found. Now, the first antibody that I've said is the protective antibody, because if this will appear, it's a guarantee that the person will not die. He is never gonna have fulminant hepatic failure, because if this appears, in majority in cases, 90% cases, it will appear. Person is not gonna come back to you, because the security system will appear in the body, the person's clinical manifestations will reduce. The antibody to the core antigen can be two classes, IgM class or IgG class. For IgG class, I want you to remember that this would be chronic viral hepatitis, and IgM class would be acute viral hepatitis. It's pretty straightforward. IgM stands for acute and IgG is for chronic. But you see, there would be another MCQ where answer will be antibody to the core antigen, and that would be the window period or the gap period of the virus. I will just explain the gap period aspect to you in a while, but at the moment I just want you to understand that for IgM class of antibody, there can be two answers. One can be acute viral hepatitis, other can be gap period or the window period. For antibody to the E antigen, remember the fact that we are going to talk about that the patient's replication rate has substantially reduced. So if the replication rate will reduce in the patient, then the infectivity of this patient to his family members will be substantially reduced. Now to see whether you've understood this aspect related to antigens or antibodies, I'll just show you this graphical representation with respect to the virus which is being asked in the exam nowadays. As I told you, the first thing to appear in the blood is the surface antigen. It becomes positive between first 1 to 12 weeks, usually around the 4-week period. So you can see that the first thing that will turn positive here is hepatitis B surface antigen. The first antibody to appear would be IgM class of antibody to the core antigen. So initially, this curve that is starting between the 4 to 8 week period, this is for the first antibody to appear, that is IgM class of antibody to the core antigen, and gradually as the time will progress, you see later on, it will be replaced by IgG class of antibody to the core antigen. Do remember the fact that when the surface antigen is falling, then the security system is coming up. So this particular part of the graph represents the security system, that is antibody against the surface antigen. If this antibody is present, it is a sure shot fact that the person will not die. You can notice here that when the surface antigen is decreasing, the security system is coming up, and there's a very clear-cut gap between the two. You will notice this in all books, whether pathology or medicine, that there would be a slight gap in the curve which would be between the surface antigen disappearing and the security system becoming well detectable. So this period is actually called as the gap period. You see, sometimes the term used is window period here, but that window period word can cause confusion with HIV window period, where I said that the ELISA test is negative because it is early day of infection. But here, the more appropriate term that now the book is using is gap period, which explains the fact that when the surface antigen is disappearing and the security system is appearing, between that, the thing that they will tell you that the patient is in the gap period or the window period is this antibody in the top that you can see, the IgM class of antibody to the core antigen. So do remember this question, that in the gap period, which antibody will only be present in the circulation? IgM class of antibody to the core antigen, because everything else will turn negative. Surface antigen will turn negative. Antibody to surface antigen is still on the pathway of becoming detectable gradually. So gap period is best diagnosed by IgM class of antibody to core antigen. I also want you to remember, and in fact, it would be great if you can hand draw this by yourself by looking from any book. Otherwise, it becomes, just listening to me, you might miss out the timelines. Like you see, something around 4 weeks, it is becoming positive. By 24 weeks, it is becoming undetectable. The antibody is appearing, IgM class of antibody between 4 to 8 week period. And this is the time when you will also notice that the E antigen in the patient will start turning positive, and mostly the E antigen will then start disappearing between 20 to 24 weeks. Do try to hand draw this by yourself. I said hepatitis B E antigen, which indicates that the person is in the stage of active replication, is between 4 to 8 weeks. You can see corresponding period here. And then the antibody against the E antigen will start appearing, which means that the replication rate of the virus is reducing and the security system has taken over. Do remember the fact that jaundice will be the last one to appear and will the first one to be disappearing. You can notice in this particular case that the next thing that I have shown in the box here of a little something around the 8 weeks period is the elevation of ALT of the patient / SGPT, both mean the same. And then is jaundice, and jaundice will disappear also faster. You can see on a comparison basis, and I'll say that again, first is surface antigen, security system, E antigen becoming detectable, then is enzymes turning out to be positive, then is jaundice, and jaundice will first disappear, then ALT will come back to normal, and then E antigen will disappear, and antibody to E antigen will start turning positive in the patient. So if you hand draw this for at least once, I would suggest that you would be in a position to solve these image based questions that he is putting. And this is one of the primary reasons that I have gone into this discussion. Otherwise, I have updated this lecture primarily because of this reason only, that the orientation for the rise and the fall of the antigens and the antibodies should be clear to you. Now, since this diagram has already been asked in the exam and the marking, I want you to practice by yourself at least once. Then they can ask you a second diagram that is given in Harrison related to hepatitis B, and they can ask you to identify the line diagram. You can notice that here the surface antigen of the patient is positive for years. I mean, 120 months is going to be like for 10 years. So either it's going to be a case of carrier or it's going to be chronic hepatitis B, and you can notice the elevations of the liver enzyme which is occurring in the patient. The hepatitis B DNA is detectable in this patient. So this tells you the fact that this person or this graph represents chronic hepatitis B. You can have a look at the two slides. Marked difference, in one the patient has shown a recovery, that is acute hepatitis B followed by security system. In this case, you can notice that the security system is not even in the picture. Rather, the patient has gone into chronic hepatitis B because the security system never showed an appearance. The virus is multiplying, the liver enzymes are elevated, so the SGPT elevations are definitely going to tell you that the disease is like a slow fire burning in the liver, and this will cause development of cirrhosis and cause a development of ESLD, that is end stage liver disease in the patient in future, which might necessitate a liver transplantation. Our role as a doctor is to prevent this progression from occurring. And how would we do that? I'll explain that in the subsequent slide. We have learned today the fact that most of the time when it comes to hepatitis B, the presentation will be that of icterus, which will take some time to appear but will be the first one to disappear, as compared to biochemical recovery will take some time, but jaundice recovery will occur relatively faster. So let's look at a question, you'll understand this better. This is a 22-year-old young college student who has come to my OPD today. His complaints are that for last 1 week he's having nausea, vomiting. He smokes with his friends daily, but he says that when I'm cigarette smoking right now, I am having a horrible taste in my mouth. So he has quit smoking. Like he says, like it's a habit for me to smoke every day with my friends. He thinks it's a cool thing to do, but he's having aversion to smoking. You would have noticed that in acute viral hepatitis in your patients, there is a mild change or significant change in olfaction as well as in the taste. So the same cigarette which was earlier giving him pleasure, the smell of the burning cigarette and the taste of the smoke might be now so bad for the patient that he'll say that I don't feel like smoking. So it's not that it's a very significant history, but I'm telling you that there's a change of olfaction and there's a change of the taste sensation in the patient during the prodromal stage. Low-grade fever may or may not be present. Fever is usually more common a presentation of hepatitis A and hepatitis E, whereas with hepatitis B, unlikely to have at least fever most of the time. So at the moment, I don't know. It could be any variety from A, B, C, D, E. So I am presuming it could be either A or E in India because of fecal route of transmission, or could be hepatitis B because I don't know the sexual history of this person at this moment. His next complaint is that he's having right upper quadrant discomfort, especially on eating food. He has vomited maybe 2 times, 3 times today, so he thought that he's dehydrated and he should show a doctor. On listening to the complaints of right upper quadrant discomfort, I straight away had a look at the white of the eyes of this person, and I noticed that his sclera was relatively yellowish. You have to check for jaundice. Not in the sunlight, not in the tube light, but in daylight. So take the patient to the corner of the room and examine the patient in daylight, when you will be able to see jaundice or icterus in a patient. Jaundice or icterus tends to appear in a person when the serum bilirubin is more than 2 mg%. Normal serum bilirubin in your and my body is less than 1 mg%. Jaundice tends to first appear below the tongue, that is on the frenulum, but it is usually not visible. I said the jaundice first appears below the tongue, that is frenulum. It will not be visible. Then it will appear in the white of the eye, that is the sclera. And the white of the eye, the sclera, has high concentration of elastin. which binds with bilirubin, and therefore you will notice that the eyes would look yellowish, the skin would look yellowish in the patient. A differential diagnosis to be remembered of jaundice here is beta carotenemia. Beta carotenemia will also be having a yellow skin, but the sclera would be normal, unlike in jaundice where both would be yellow. The next thing that I noticed in this person was a tender hepatomegaly. The liver span of this person was increased. So when I was doing percussion to check for the liver dullness, he was having a expression of pain on his face or discomfort on his face. The liver span of this person was 18 centimeter. Normal liver span is about 12 to 15 centimeter. I also checked for any evidence of ascites, caput medusa, or pedal edema. This is because I wanted to check whether it is chronic liver disease or it is acute on chronic liver disease presentation. As there was no ascites, no caput medusae, and no pedal edema, this told me that this is unlikely to be a presentation of chronic liver disease, and this is acute hepatitis presentation before me. Therefore, I have advised this young chap to go in for some tests. Let's look at the workup report of this person. When I have checked the liver function test, the serum bilirubin is elevated, the unconjugated variety. The liver enzymes are also diminished. SGOT and SGPT both will be elevated in this case. SGPT will usually be more elevated than SGOT. You are aware that SGOT is more specific for alcoholic liver disease, and for viral hepatitis it is SGPT. Serum alkaline phosphatase will be normal to slightly elevated in these patients. I mean, serum alkaline phosphatase significant we only consider when it is 4 times elevated. So the liver report of this patient will mostly be deranged enzymes going into hundreds and thousands. However, if you get a question in which serum bilirubin is elevated of the conjugated variety, see in this case it was unconjugated that was mainly elevated. If you get a report where conjugated is elevated, SGOT, SGPT can be normal to slight elevation, but SAP is having up to 4 times elevation. I'm writing 4x here. Then I'm dealing with a question dealing or having an answer as etiology of obstructive jaundice. In case you get a question in which unconjugated bilirubin is elevated, but SGOT, SGPT, SAP is usually normal, it means that the patient is having hemolytic jaundice. Hemolytic jaundice can even be having a enlarged spleen, because most of the time hemolytic anemias will have a splenomegaly. So what we are discussing today is hepatocellular jaundice in a patient which will be having a tender hepatomegaly, hemolytic jaundice which will be having a splenomegaly, and obstructive jaundice will be having features which have been discussed separately in conditions like primary biliary cirrhosis, primary sclerosing cholangitis. So you can go through the lectures there. But obstructive jaundice will have very classical features of pruritus and clay colored stool. And my patient, the young college student who came to me, he is having the report that I've shown in color black. And for comparison, I've written 2 reports before you, because in questions lots of time LFT reports are given, so you should be able to do a quick representation and interpretation. I will now be doing an ultrasound of this patient to check for the echo texture of the liver as well as the span of the liver and the size of the liver. When the report came, it said starry sky liver. Now you are aware of starry sky kidney, that is post streptococcal glomerulonephritis, but starry sky liver is a feature with viral hepatitis, and the span of the liver of this patient was substantially elevated. In point number 3, we shall be discussing regarding a simplified diagnostic algorithm that will help you know the etiology of the viral hepatitis that is occurring in this patient. The tests which are mandatory to be written initially are hepatitis B surface antigen, IgM class of antibody to hepatitis A, then would be IgM class of antibody to the core antigen, and lastly antibody to hepatitis C, that is anti-HCV antibody. Let's look at the permutation combinations that he can ask you in the simplified diagnostic algorithm, and these 4 things that I mentioned is itself a question. The word is simplified diagnostic algorithm for acute viral hepatitis. The tests are written in front of you. Let us assume that in the report this permutation combination is given, the one that I have highlighted currently. Then the diagnosis of the patient would be given as, because surface antigen and IgM antibody core antigen is present, we know our diagnosis is acute Hep B. Possibility number two is that only IgM class of antibody to A antigen is positive. So you know, in this case where only IgM class of antibody to A antigen is present, this is a case of acute hepatitis A fecal transmission. The next possibility is that only antibody to C antigen is positive. This means that patient is having acute hepatitis C, recently acquired infection. The third possibility is that all of these tests are negative. All of them are negative. Then you will say that the patient is having non-A, non-B, non-C infection. Non-A, non-B, non-C means that you narrow down the diagnosis to D and E. And when it comes to comparison of D and E, you can differentiate, because if it is gonna be E, then it's gonna be acute presentation, fecal as common in India, and D is mainly gonna be history of IV, drug abuse, sexual promiscuity, homosexual male, men having sex with men. So he says that to save costs, this what I'm discussing is not an Indian protocol. He has mentioned this in Harrison, and he is calling it, and has been asked in the exam also, simplified diagnostic algorithm for identifying etiology of acute viral hepatitis. Mark my words there. He's not saying that you are diagnosing hepatitis B or you are diagnosing acute viral hepatitis here. We are finding the etiology behind development of acute viral hepatitis. The diagnosis of acute viral hepatitis are made on two things: jaundice with hepatomegaly clinically with deranged liver enzymes like SGOT, SGPT. I know my diagnosis. It is a viral hepatitis in a patient. But what is the etiology? It is a simplified diagnostic algorithm. Now, I am assuming the fact that if it is acute hepatitis B, then subsequent testing of the patient would also be required in follow-up visits, because patients of hepatitis B, 90% will recover, but some will deteriorate and can go into cirrhosis, and some can go into fulminant hepatic failure also. Do we have fulminant hepatic failure with acute hepatitis B? The answer is yes. The incidence is 0.1 to 1%. Let us now look at what treatment will I offer if the question mentions acute viral hepatitis in a patient. This case has been finally diagnosed to be acute Hep B. We do not need to use antiviral drugs like tenofovir and entecavir in these patients. We will give bed rest to these patients. For the nausea component, you can use etopride, mozapride for the patient. For the dehydration component, you can give some IV fluid. If he's not eaten anything since morning, he's having vomiting on eating everything, you can give dextrose to the patient, followed by a bit of normal saline to correct the dehydration component. So conservative management will be done in acute hepatitis B, and you will monitor the patient. And most of the time, as I said, when you call the patient for follow-up, patients would not come back. However, since in the exam we are expecting an ideal scenario where patients are coming back, so let's now look at the table, which will be the most important part of this discussion with respect to the fact that he can give you these serological informations of hepatitis B virus simultaneously. The question will mention regarding four things together: surface antigen, antibody to the surface antigen, which might be written only as anti-HBs. Then would be antibody to the core antigen, and lastly we'll mention hepatitis B E antigen. So four things are given. Let's look at the various permutation combinations in the reports that can present or reports that can be given to identify the stage of the disease. In the first consultation, the report will be like this: the security system will be missing. The class of antibody, the first antibody to appear is IgM class of antibody, and the E antigen in the patient is positive. So you will answer that this person is having acute Hep B. For diagnosis of acute hepatitis B, you have to see two things in the blood: surface antigen positivity and IgM class of antibody. So both are positive, acute hepatitis B. And because E antigen is positive, so the infectivity of this particular individual to sexual partner as well as to doctor nurse handling the blood sample is definitely increased or exaggerated. Now, there's a possibility that in the question he will give you the same report, but you will notice that the antibody given will be IgG class of antibody. The virus is still multiplying, So you will change your diagnosis because IgG class of antibody is given to the patient. So your answer would be given in this particular case as chronic hepatitis B, and the virus is showing an active replication. So we need to treat this patient with antiviral drugs like tenofovir or entecavir to prevent the conversion into cirrhosis. When I will give this treatment to the patient, what's going to happen is that the same patient will now turn surface antigen negative. Why? Because I've killed the virus. The security system will turn positive in the patient. The antibody to surface antigen will become detectable in the patient. The class of antibody for core antigen IgG will remain the same, but E antigen will turn negative in the patient. Why? Because I've killed the virus. So the report that I have shown now to you will indicate that the patient has had a biochemical recovery from the virus. What I mean by biochemical recovery is that the liver enzymes in the patient will also start reducing, and the serological recovery is also occurring in the patient. So biochemical and serological recovery will be noticed in the patient because the surface antigen and the virus is not causing now substantial damage in the liver. The fourth possibility is that everything in the report is negative except for IgM class of antibody to the core antigen. This is the most important part of the discussion, and this would be called as the window period or would be called as the gap period. Remember that in gap period, when the surface, I'll just show you the slide again so that you can remember the gap period here. The gap period is the time when everything is turning out to be negative. Surface antigen is decreasing, security system has not appeared, only IgM class of antibody initially is present, and then it will get converted into IgG. In fact, in some books, you will notice two curves. The IgM antibody from here is going down, and then IgG antibody is continuing forward. So initially, you have IgM antibody. I've shown a spike here, then IgM antibody will begin to fall here. Out something like 4 to 5 months, the IgM antibody will fall and IgG antibody will appear. These two antibodies will appear for whole life of the patient. They persist. IgG antibody to core antigen and antibody to surface antigen, they remain for whole life of the patient. IgM antibody will obviously disappear gradually. Therefore, this report that I've shown before you, where single report is given, IgM class of antibodies gap period or window period, the next possibility is that only thing positive in the patient is the security system. Nothing else is positive. This is vaccinated individual. You will notice that the inferior two data are easy to remember. Why? Because only one thing is positive in the patient. In gap period, it is IgM antibody to core antigen. I hope you have noticed that if IgM antibody to core antigen alone is positive, it is gap period or window period. If two things are positive, surface antigen and IgM class of antibody, then we will say acute viral hepatitis in a patient. Last but not the least, I'm going to give you a report which is more of a AIMS-based question, but still because they've asked it, we'll have a look at it. You can see that in this case, the only thing positive is IgG class of antibody. So what can be the possibility in this case? One, and the more higher probability in this patient is that this patient is a low level carrier. The meaning of the word low level carrier will be the surface antigen in the patient is beyond the threshold of detection. I mean, whatever is the minimum required by the laboratory kits that are available, it is below that particular threshold. The second possibility can be remote infection, which means that the infection occurred a long time back. The person's body has cleared the surface antigen, but till the immunological memory of the infection is very much there, because antibodies, once they appear, they persist for whole life of the patient. So this table that I have just made before you, I would like you to just make this table once again, so that if they give you questions on this scenario, you are able to identify this. What you learned from this table is the following information. I'll highlight the important ones. If you read a question like this, hepatitis B surface antigen positivity with IgM class of antibody to the core antigen positive, it means that patient is having acute Hep B. The replication part will be determined on basis of E antigen. If the same report is written partially and the antibody is changed to IgG class of antibody to the core antigen, then it implies patient is having chronic Hep B, and that is the patient who requires antiviral treatment. E antigen positivity implies that the virus is still multiplying. In case you get a report in which only IgM class of antibody alone is given, that indicates the gap period. Alone in the patient, antibody to surface antigen is present. This indicates that the patient is vaccinated, security system has taken over. If alone IgG class of antibody to core antigen is given in the patient, then there are two possibilities. Either is a low level carrier. I'll write that word once again. That means that surface antigen is below the threshold of detection. Second possibility is that it could be a report infection occurring in a patient. Immunological memories will always be there once the antigen has shown its physical presence. Once you get this orientation right for this table that I have just explained before you, so we will look at treatment of this patient. Treatment is given of antiviral drugs for patients of chronic hepatitis B. How do you know it is chronic? I told you the serological report. You will check E antigen in the patient to determine the infectivity of the patient, and you will now be doing a PCR, and that's the usual question that you will notice lots of time coming up, that what test will be done in the patient subsequently. Like if you know is a case of chronic hepatitis B by serological information and the liver enzymes are showing a serial rise, you will do a PCR hepatitis B DNA. If the report says that the patient is having more than 20,000 international units of DNA circulating per ml of blood, and simultaneously in the question SGPT elevation is 2 times the upper reference limit, it means that the treatment of the patient has to be started. In some cases, he might mention that he is a patient of compensated cirrhosis. Compensated cirrhosis will not have features of portal hypertension, ascites, or coagulopathy. You see, if portal hypertension, ascites, and coagulopathy will develop, that all means that he's gone into decompensation. So, compensated cirrhosis patient, I will again be doing first a E antigen to check whether he is reactive or not, because E antigen is going to tell me the infectivity of the patient, and the virus is multiplying, right? So I need to be aggressive. In this case, the PCR cutoff, however, is slightly different. So if a person is having compensated cirrhosis, then the cutoff in this case is 2 into 10 raised to power 3 international units per ml. And the liver enzymes of the patient should be elevated, but it is not at least a 2 times elevation. I mean, even if it is slightly lower, we'll still initiate treatment for the patient. So these two reports, if given in the question, either of the two informations given like this, then you have to initiate treatment. And the drug of choice for this condition will be answered as tenofovir. Keep a watch on the kidney function test of the patient. The alternative drug that is given to the patient is anticavir. Tenofovir would be given as 300 milligram dose once a day for total of 48 weeks. In fact, most of the treatments of hepatitis B would be for a huge duration of 48 weeks. So compliance is important, because we can use injections also, like pegylated interferon, alpha interferon, but then with injections, the compliance part will significantly be reduced. So most of the time tablets are the ones which are recommended, and these are the drugs that I want you to remember. To finish this topic, lastly, I would like to also mention regarding this statement which I made right in the beginning, that is pre-core mutant will be having E antigen negative. So therefore, this is a disease that is more common in, or this virus is more common in Russia and Europe basically. The clinical features are relatively more severe in this particular case. And I would also like to mention regarding a term by the name of escape mutant now. This is a clonal evaluation of the virus, or rather evolution of the virus, I would say, because escape, as the name suggests, then the virus will resist inactivation, or the virus will not be inactivated. Now this is a big problem, no? If the virus will not be inactivated by the security system, then it will continue to cause damage. So look at the surprising thing that I'm telling you, the escape mutant will not be inactivated by the security system. This is a big challenge. This is like a science fiction, no? The virus does not respond to the security response. So these are two problems that we have to remember. And with treatment, as we are giving so many drugs indiscriminately sometimes also, then the virus might become resistant, and has already become resistant to most of the drugs. So this is definitely a challenge for most gastroenterologists if they are dealing with, or hepatologists if they are dealing with the hepatitis B. It's a PCOR mutant or escape mutant. But thankfully the Asian virus has not shown, the Indian virus has not shown these aspects. So we are still on safe zone as far as this infection is concerned. The most important part of this discussion would be, one, to get these curves right that I mentioned, and I would like you to please practice by hand drawing them once, otherwise visual memory might fail you. And this table that I mentioned in the end, if you can get this right in the first go, then you are bang on target to understand the disease. Thank you so much for your patience for listening me out on this topic.